left ventricle we see 2/3 of, and we see all of the left atrium. So left ventricle and left atrium, okay? The only thing we see on the anterior surface of the heart for the left atrium is the orbital. And we have 2/3 of the left ventricle and 1/3 of the right. So all of the left atrium and most of the left ventricle is what forms the posterior surface of the heart. It's resting up against the posterior wall of the heart. All right, in fetal circulation, do right and left ventricles pump with the same volume? Do right and left ventricles pump with the same pressure? Or is pulmonary pressure greater than systemic pressure? Do coronary arteries fill with blood during ventricular systole? So do right and left ventricles pump with the same volume? Yes, they need to do that, or we have a backup and issues with edema, pulmonary or systemic edema. Do they pump with the same pressure? No. So that they don't pump with the same pressure, is pulmonary pressure greater or is systemic pressure greater? Think about the ductus arteriosus we talked about earlier this evening. Pulmonary. That's what causes the blood to leave the pulmonary artery and go into the aorta, is because the pulmonary pressure is higher. So it diverts to the lower pressure. Okay? And coronary arteries fill during diastole, when the valves close and they move away from the coronary. Semilunar valves move away from the coronary arteries and allow blood to move into them. Okay? All right, cardiac tamponade, do you remember what that is? We talked about it when we talked about the pericardial sac. And Steve Irwin and the IV needle that went into the pericardial cavity instead of staying into the subclavian vein. So when fluid builds up in the pericardial cavity, be it blood or IV fluid, that's cardiac tamponade. So the ventricles cannot fill as much with blood. So what happens to stroke volume? It decreases. So if stroke volume is decreasing, what's going to happen to heart rate to maintain cardiac output? It's going to go up. Okay. So here's an image of the increased fluid volume and the pericardial sac restricting the expansion of the ventricle. All right, acetylcholine. Does it bind ligand-gated ion channels in autorhythmic cells? I didn't read this carefully last night and I did it wrong. Does acetylcholine bind to receptors in autorhythmic cells? Are they ionotropic or are they metabotropic? They're metabotropic, so it's not ion channels. It does bind to receptors, but they're G protein coupled receptors, not sodium ion channels. So that was a little tricky. I missed seeing the ion channel last night. Okay, does it activate inhibitory G subunits? Yes. So the alpha subunit is an inhibitory form and it decreases cyclic AMP. Does it activate stimulatory G subunits? No. It does close transient calcium channels, all right, but that's through the alpha inhibitory. Does it open potassium channels? Yes, with the beta gamma. That's the first time we've really talked about using beta gamma. Is that part of this G protein that opens the potassium channels? Okay. That was S. Okay. I was like, what? But it's true if it's an inhibitory, not true if it's an S. So let me go back and change that. I don't think it matches this. Because if that's an inhibitory, it's true, but in the previous slide, that was an S, so we'll change that to an I. And it does not close the calcium channel. So that's the image I showed earlier this evening when we're reviewing the effect of acetylcholine. Okay? Do you remember what monoamine oxidase does? MAO? Yes. So monoamine oxidase is inside the axon synaptic bulb, and norepinephrine, after it's released, when we want to remove it from the synaptic cleft, it's not broken down near the binding site, like acetylcholine is, it's taken back up into the neuron. I don't know if you've ever heard of SSRIs. So those are the channels that take it back up into the axon, and the monoamine oxidase is what breaks it down. So when we inhibit that, what's going to happen to the amount of norepinephrine in the synaptic cleft? If we're not breaking it down, norepinephrine, then norepinephrine is going to go up. Okay, it's one way of increasing the amount of norepinephrine in the synaptic cleft. So if we have more norepinephrine, is that going to increase intracellular calcium ions? Yes, it's going to do so both for the SA node, because it's going to open up the more of the transient calcium channels, and it's going to do that in the contractile cells, because it's going to open up more channels in the sarcoplasmic reticulum and more channels in the plasma membrane of the cell itself. Does it increase heart rate?
Yes.
Yes, it does that with the cyclic AMP, increasing the funding channels and the transient calcium, so we get to that gradient potential, the threshold potential faster. Does it prolong the PR interval? No, because it's causing the AV node to depolarize faster as well, okay? So it's not going to prolong the PR interval. Does it increase cardiac output? Both ways. It's going to increase heart rate, and it's going to increase contractility, so it's going to increase stroke volume. So it's going to increase cardiac output because it increases both factors that affect cardiac output. Okay? So it increases cardiac output by increasing stroke volume and contractility. So this is the axon. This is just showing the monoamine oxidase. So norepinephrine is taken back up into the neuron to be broken down. So if we inhibit that, then the norepinephrine builds up in the space. Which of the following would function to increase blood pressure? All right, so terminology here again that we need to review. The concepts are simple, you just need to understand what the words mean. So adrenaline is another word for epinephrine, all right, which acts like norepinephrine. So an agonist promotes or blocks. That's an antagonist. An agonist is going to promote. So an adrenergic agonist is going to do the same thing as norepinephrine. It's going to bind to the same receptors, and it's going to act just like norepinephrine. So it's like having more norepinephrine. And we know that norepinephrine is going to increase blood pressure. Okay? Cholinergic blocker. So it's going to increase blood pressure, because what we're doing here is we're blocking acetylcholine from binding to its receptor. So by inhibiting acetylcholine's effect, we're allowing the sympathetic effect to increase. So that would increase it. We already talked about the MAO inhibitor, so that will increase it, okay? So cholinergic agonist. That's going to act like acetylcholine, which would be to decrease heart rate, and that would decrease blood pressure. Acetylcholinesterase, that's going to increase blood pressure because it's going to remove acetylcholine. It's going to be similar to a cholinergic blocker. Acetylcholinesterase is the enzyme that breaks down acetylcholine. So if we break down more acetylcholine, again, it's removing the vagal influence and increasing. And then finally, cocaine, yeah. Yeah. Okay? All right. Which of the following function to increase venous return? So as we increase venous return, what are we doing to end diastolic volume? Those are almost interchangeable. End diastolic volume is the volume in the ventricles at the time the ventricles close the AV valves by contraction. Okay? So that is a measurement of venous return. End diastolic volume goes up, venous return goes up. So ventricular fibrillation. Do we have any blood movement with ventricular fibrillation? No, because we have no stroke volume. So we have the ventricles just doing this. Venous return is going to fall to 0. Okay? So it wouldn't be that. Exercise? Yes, through 2 forms. Exercise is going to increase heart rate and stroke volume, and your skeletal muscles are going to contract more and squeeze the blood back up to your body from the lower extremities. Atrial natriuretic hormone release. We just talked about that tonight. That's the only one of the hormones that does increase it. So remember aldosterone? Oh, sorry, you're right. Yes, it decreases it because it causes urine to leak. That up here. Okay, so aldosterone and ADH would increase it. Increased cardiac output? Yeah, because the more that goes out, the more has to come back. Aldosterone release. It's going to cause increased venous return because we're going to increase blood volume by returning sodium to the blood. We're going to return water to the blood. Diuretics? No, we're going to lose volume. The Valsalva maneuver. The Valsalva maneuver squeezes the heart. Okay? And I did this exercise for the students last night. I haven't done it for you yet. It's something that when I had the paper version of lab reports, everybody did it. So remember, pressure has to be lowest at the heart as well as highest, or we don't have blood cycling. The blood has to be high where it's leaving and low where it's coming back. Okay? So, remember the dorsal venous arch we talked about? Where that forms over the tendons in my hand, the back of my hand, as I let the blood gravitationally flow into that. I have lost enough collagen and elastic fibers as it fills with blood, it creates a little ridge I can actually feel. Okay? So if I estimate where the right atrium, which is where blood is returning from my body system, if I estimate where the right atrium is here, then to overcome the pressure that's already there, I have to raise my hand above the level of my heart to get that to collapse, showing that the blood flow is moving back faster than it's building up in there. So what I want to do is look to see when that ridge that's in there flattens down to the level of my tendon and isn't higher than that anymore. So, and then I'll mark it. Now that I need to do it, it's not going to be. Of course, for all you know, I'm just making this up. All right, so there's a formula. It's actually in your lab packet where we measure this in millimeters and divide by the specific gravity of mercury. And we come out with the pressure at the right atrium, which is usually between 5 and 7 millimeters of mercury. Okay? Now, I'm going to do the Valsalva maneuver, which is closing your nose and not letting any air out, like that. Squeezing, pushing the diaphragm up, squeezing the abdominal muscles as if you were trying to have a bowel movement. Then, like I said, don't worry, I'm not going to do that up front. So I'm just going to bear down. And what's that going to do to the pressure inside my thoracic cavity? It's going to increase it. So if it's squeezing my heart, I'm going to decrease the amount of blood that can actually flow back into my heart because I'm squeezing it with the chest muscles. Okay? So I'm going to do that now. It usually makes me a little faint because I'm not letting any blood go out either. So I might close my eyes and shake my head a little bit. I'm just trying to get rid of the gray that's in my eyes. Okay. Must have squeezed harder than I did last night. It went a little higher. Right now my ears are all stuffed up. Okay, so that's how much higher I had to raise my hand to overcome the pressure in my right atria due to the Valsalva maneuver. Okay, so that was showing an increase in intrathoracic pressure. Now, normal breathing actually helps to move blood into the heart because when you breathe in, what are you doing to pressure in your thoracic cavity? You're decreasing it, so that's going to help blood move into the heart. And then when you breathe out, like I just did, except exaggerated with the Valsalva maneuver, so breathing in actually helps to lower pressure and helps to move blood into the heart. But that squeezing activity squeezes the heart, and that prevents blood from coming back in. Okay? Okay, next question. You're ready. So which of the following happens at the end of isovolumetric relaxation? So isovolumetric relaxation, we're isovolumetric when we have both the semilunar valves and the atrioventricular valves closed, right? So if we're in relaxation, that's occurring during the T wave as the heart is relaxing. So at the end of isovolumetric, all right, thinking we're right at the end, so we're at the beginning of the TP interval. Because T is the beginning, the T wave is the beginning of the isovolumetric. So the Is that the beginning of ventricular ejection? No, that would be the end of isovolumetric contraction when we open the semilunar valve. Beginning of ventricular filling? Yes, because I just said a TP interval. Aortic valve closes? No, that's going to be the beginning of isovolumetric relaxation. As the ventricles relax, the aortic pressure becomes greater than ventricle pressure, and semilunar valves close, and that's the beginning of isovolumetric. Ventricular pressure is lower than aortic pressure? Yes. Ventricular pressure is lower than atrial pressure? Yes, because at the very end, that's what allows the AV valves to push open. As the atrial pressure is, we're right here, and that's why the AV valves are opening. And they open because atrial pressure is pushing them open. Okay? All right. Let's stop here on this section because I want to do some more on Wednesday night, and let's move forward to let's do some of these action potentials and stuff. We won't do all of them, but just to give you an idea, and then we'll do some of them like that. Okay. So, what channel, what is this membrane potential? What channel, what ion? Is it ligand gated or voltage gated channel that produces this increase, this depolarization? Are we looking at autorhythmic cells or skeletal muscle cells or contractile cells? Autorhythmic, okay? So this is part of the action potential. So what ion is moving into the cell there? Calcium, okay? Is it a ligand gated or a voltage gated channel? Voltage gated, okay? So voltage gated, long lasting calcium channel creating the action potential. Now, unfortunately, the line's down here at the bottom. So V is the repolarization that's occurring there. So what kind of channel is that? It's still part of an action potential. So is it going to be ligand gated or voltage gated? Voltage gated, and for what ion? Potassium. Okay, so you will have questions like this, fill-in questions like this on the exam next week. I'll have a similar diagram to this, and a line saying, identify this action potential, identify the channel that opens or closes here, type of thing as you look at that. So almost identical to this, okay? So C, and I apologize for that being so, C is right here. So what cell are we looking at? Contractile, cardiac contractile cells, all right? So what, ligand gated or voltage gated? Voltage gated, and for what ion? Sodium, okay? And then D, where we see the beginning of the plateau. Voltage gated, calcium, fast, slow, or transient? Slow. Okay? So that's the type of thing that, and we'll look at more of them on Thursday. And now let's do some blood vessels. All right, so the superior vena cava is formed by the union of what vessels? Get you prepared for the quiz on Thursday. Okay, got a brachiocephalic here. Let's see if you're right. Both brachiocephalic. So we have a short right one and a longer left one coming together to form the superior vena cava. As zygus drains into it, it doesn't form it. Okay. The popliteal vein or popliteal vein is formed by the union of posterior what? Tibial, and the other one is No. Fibular drains into posterior tibial. What is it? Fibular drains into posterior. Posterior and anterior. Alright, so here we have the posterior view of the lower limb. Here's the anterior tibial draining into posterior, coming together right there, and there's fibular draining into posterior tibial. So posterior tibial and anterior tibial come together and form the popliteal vein. Okay? The superior adrenal artery is a branch of the inferior phrenic. Alright, so here they're showing several of them, and remember I told you I drew it very far away, but in actuality the kidneys are pretty close to the diaphragm. Okay, what are the three branches of the celiac trunk? Left gastric, hepatic, and splenic. Okay? The cephalic vein and the basilic vein drain into axillary. Yeah. So cephalic drains into the axillary just as it begins, as it transitions from brachial. And cephalic drains into axillary just before it becomes subclavian. So they both drain into axillary. Inferior rectal veins drain into the internal pudendal. Internal pudendal. Middle rectal drain into internal iliac. Superior rectal drain into inferior mesenteric. Okay? So here's the bottom, inferior rectal going into internal pudendal, middle rectal going into internal iliac, and superior rectal into the inferior mesenteric. Alright, portal vein is formed by the union of splenic and inferior mesenteric drains into splenic. So it would be splenic vein and superior. I just typed that question into your exam today. The deep palmar arch is supplied primarily by ulnar artery. No.
No.
Radial. So remember the radial that comes through the web space and forms the deep. Hepatic artery is found with what vein? I mentioned it earlier today when we were talking about fetal circulation. Portal vein. They're both carrying blood. One is oxygenated, one is deoxygenated, but rich in nutrients, and they're going together into the liver, which is unusual. So here's the hepatic artery lying anterior to the portal vein. This is the gallbladder duct on there. The fibular artery is a branch of the fibular artery is a branch of the posterior tibial, just like fibular vein drains into the posterior tibial. All right, so here's the anterior tibial disappearing between the tibia and the fibula, and here's the fibular artery giving rise to the ankle. Dorsalis pedis vein drains into the anterior, off of the foot. Okay. The lateral aspect of the foot and ankle. I neglected to put one word on here, which I will always include if I want this level of drainage, and that is this word. It makes a difference. Come on, okay. So draining the skin of the lateral foot and ankle. Yes, I heard it. Small saphenous. The fibular would drain the deeper tissue, okay? But if we're draining the skin, medially would be great saphenous, laterally and posteriorly for the lower leg would be the small saphenous, okay? All right, so we'll do a little bit more of this on Thursday, and we'll also do some tracing questions. I know I've been promising them to you. There's some online, and there's some in your lab as well, or lecture notes. Okay? So that's our formal. I talked for 3.5 hours. You've been kind enough to listen. So we will start blood cells on Thursday. I have the lecture notes. That material will not be on your exam. Okay? And I don't like having an exam 2 days after we finish lectures. I like to have the weekend. But we will start the blood cells, and then lab will be some more review, and the last opportunity formally in class to study the heart models and the vessels. Okay? Alrighty? For the rest of the